We shall now go on to our next speaker, Dr. ANAND VINEKAR, who is a professor and head of the Department of the Pediatric Retinal Services at Narayan Nethralaya Eye Institute, and is been the founder, program director of this amazing ROP program, which he had initiated, and probably one of the largest in the world. And he is going to be telling us about bringing order to pediatric vascular diseases. So on to you, Dr. Anand.
Thank you, Chitra ma'am, and thank you, Srinivas and the AIOC ARC committee for this opportunity. I'm going to be talking about angiography in infants and pediatric cases. So, well, there are currently two devices that can be used. One is the RedCam 3. That is really not portable, so one has to keep it in the institute, so we don't really move it out. And the other one, which is just now commercially available, is the same Forus Trinetra Neo, which has now come up with a FFA module. This was during the clinical trial where we had actually taken it into an NICU where we have used it. So it's a little more portable. But the process and everything else remains the same. 10% sodium fluorescein, some people have used 20%. That's the dosage, 0.077 ml per kg. This is the Baskin-Palmer regime that was published over 3 decades ago. Test dose is not really mandated. Of course, you must have an IV cannula and a resuscitation equipment. Either the neonatologist or the pediatrician should be around, and keep the baby for observation and tell them the post-procedure instructions. I've really structured this entire talk into just cases without much theory for our younger audience. So first I'll deal with the non-ROP type of entities and then ROP. So this one you'd really mistake for ROP because it's no different actually. But when you realize the term vitreopathy, a part of FEVR, and you look at that leakage in the middle panel lower in the angiogram, that leakage which is actually coming from at the interface between the vitreous body and the retina. And of course, we know that this is FEVR because subsequently this child was proven to be genetically proven, but otherwise could have easily been mistaken. Falciform folds then give you a sort of indication that this could move towards FEVR, and this is the same child in one eye and a falciform fold, and in the other eye, very innocuous looking stage which can be picked up on angiogram. So the idea is FEVR is unilateral only in about 15% of cases, and angiogram helps us decide, especially in these asymmetric cases, when to do the treatment. Now, obvious cases of coats or coats-like reaction, you see exudation, you think coats in a male child with one eye, really important to rule out other entities that mimic this, right from retinoblastoma, FEVR itself, PFVS, nories, and so on. The lighted bulb appearance, which is so commonly spoken about in coats, is not as commonly seen. Of course, in the periphery, you can see telangiectasias only in the earlier phases. In the later phase, it all looks like a diffuse leak. But the whole idea is to pick up the ischemic areas so that you can target the treatment, either with anti-VEGF, with laser, cryo, or even surgery, depending on how severe the condition is. Now, this is a condition, incontinental pigmentia, not as uncommon in India as thought out to be. It's an X-linked dominant condition. And you see these pigmentations, often the diagnosis is made by a dermatologist or a pediatrician. And if you're lucky, then you see neovascularization and you have the ability to do the treatment. Often, unfortunately, these babies come with already advanced retinal detachments, sometimes in one eye, and therefore you need to make a diagnosis. And this is where angiography, showing you the neovascularization, and here on the OCT, the NV as well, then we can make a very selected treatment. Nories disease, again thought to be not so common in India, but the key word here to remember Nories is dysplasia. So an aplastic or a dysplastic looking retina, where there are hardly any features of what looks like a retina, which otherwise would mimic FEVR, is therefore Nories. And of course, genetics would be the only way to prove it. And this neovascularization and the ischemia is extremely intense. It's very gross, and usually what looks like a very bad NVD or a very small amount of retina that is viable around the disc. I've clubbed a few conditions here, hematomas and other syndromes. So this ash leaf spot, if we care to look at the rest of the body of the child which comes with an eye problem, you can pick up many of these conditions who present with seizures and cortical vision impairment when they actually have tuberous sclerosis. What I want to show you here is the mismatch between what an OCT can pick up and the angiogram picks up. When the surface of this hematoma is really irregular, the smaller capillaries are going to be leaking the dye, and that's how it's picked up, maybe as a stain, maybe maybe as a leak, as you see in this lesion. In another lesion, which is so easily picked up both clinically and on OCT, it's not lighting up on the angiogram. Smooth surface, no choriocapillaries, no capillaries on the surface that are leaking. So it's really important to correlate your clinical findings and not always go on angiogram. So this is really the reverse. And again, this is the fellow eye of the same patient, not picked up on angiogram, but picked up on OCT. This is a 4-year-old who presented with bilateral combined central retinal venous occlusion and central retinal artery occlusion. The child had an acute exacerbation of a nephrotic syndrome. Fortunately, as you can see in that picture, there was cilioretinal artery sparing, and the child recovered to 6/12 after about 7 or 8 months. This picture is borrowed from Mike Treacy, and what's important here is the capillary hemangioma looks scary, medusa head, but really important for us as ophthalmologists to refer back to the pediatric neurologist, because a lot of these conditions have midbrain abnormalities which have to be co-managed. Coming now to the ROP part, where FFA really holds a strong point is in cases which require pre-treatment or follow-up after anti-VEGF. Now, in this condition, this baby was injected more than 4 months back elsewhere. And you can see these pre-retinal lesions sort of almost sitting on like epiretinal membrane-like things, these white spots. And we would have thought that they would light up on angiogram, but clearly it doesn't. What looks like an immature retina is actually avascular periphery. And you see this leading edge, which is leaking. So this is where you know, and this is 360 degrees. This term now has, this entity now has a new name in the new classification, which is persistent peripheral avascular retina. And we know, of course, that it must be lasered. And angiogram can help you exactly delineate till where you need to laser, and it's very accurate, heals very well. And if you do the angio about 6 to 8 weeks after the initial treatment, you can see its resolution. Sometimes you get a recurrence which is more like this, which is a classical stage 3 recurrence after the initial angiogram, after the initial anti-VEGF, and this is not throughout. So you see a stage 3 kind of recurrence in the upper temporal quadrant, but a more diffuse kind of leakage in the superior area. And again, when you look nasally, it looks more classical. So again, angiogram helps you pick up which parts are leaking more profusely for more posterior laser, and which are more the blunted leakage where you can just go up till the edge. Again, important thing is to do the laser thoroughly, and in some cases you might actually need to laser on the NVE, and as you can see in the follow-up angiograms, these then completely resolve. What was the old NVE actually then starts just floating up, as you can probably appreciate at about 10 or 11 o'clock in the top picture. This is a case that was injected almost a year back in one state, then migrated to another state, was lasered. But you can see that, I mean, don't look at the angiogram first, just look at the RETCAM picture. It looks fairly okay, except that the laser marks look scattered and probably irregular. The retina itself, except that upper nasal front, looks like, okay, this could just be followed up. But we'll be so wrong if we don't assess this fully. And you can see then the angiogram, because of the skip areas or the inadequately done laser, look at the activity. And this is 1 year after the initial injection of aggressive ROP. So this really requires a very thorough, complete laser, and angiogram, again, of course, can help you decide till where and till how much. And this is a follow-up angiogram, which almost shows complete resolution of the NV, except that one little posterior front here, which had to be then lasered subsequently just on that area to finally give a complete resolution. This is one of our pictures from one of our publications to show that the capillary non-perfusion in aggressive ROP, earlier called aggressive posterior ROP, and one of the reasons why it's now called aggressive ROP with the drop of the word posterior is because of this panel below, where the CNP areas can exist and can occur so much more anteriorly. And while we are trying to focus on what's going on posteriorly, a majority of the pathology is actually happening much more anteriorly. And it's so important to recognize this and then treat. In recent advances, I really want to talk about our little bit of experience in doing OCT angiography in these babies. This was our very first case report where we looked at OCT angiography to not only realize that this flat new vessels in aggressive ROP was not on the surface, but way deeper. And if you selectively laser that, and you can see on the follow-up OCT angiography that all the deep new vessels really disappear. And then we had a more follow-up study on these slightly older infants on OCT angiography and found that the FAZ and the deep capillary plexus look so different in 6, 9 or better vision children between the age of 5 and 10 just because they had historical ROP. So their vision could be normal. Ophthalmoscopically, they can be normal, but on OCT angiography, they show abnormal deep capillary and superficially capillary plexus. So that's really a subclinical viewing of what's going on in these small retinas. And this is some software that we started playing around with to give us an angiography-like picture, but without the dye. And this is the standard picture, and this is what's called the Vesselness Protocol. And you can see the smaller capillaries go beyond which we would have picked up on an angiogram, but not without a dye. So this is one of those software-related enhanced dye-less angiography studies. And you can see this on the left is the original, the native image, and the software is played around. You can see the occluded vessels much better in the red-free picture there on top and the Vesselness Protocol below. Similarly, with the occluded artery baby, which I showed you before, and you can see the cilioretinal artery sparing in the enhanced pictures. The importance, and this is my last slide, the importance of the fact that angiography is coming to stay now in infant imaging is the fact that it has made a mention in the international classification of ROP that was released last year. In fact, the whole spectrum of aggressive ROP has been rewritten just to show us that capillary non-perfusion that can be picked up better on angiogram than clinically is now going to be probably a new way of not only following up these conditions, but perhaps even in diagnosing it and treating these conditions. Thank you very much.
Very amazing talk, Dr. Anand. Really, truly enjoyed it. Excellent talk. And look forward to discussion by Dr. Anand Rajendran.
Yeah, as usual, an excellent talk. It's always a pleasure listening to you on pediatric retinal diseases. I'd just like to add that you almost covered the entire spectrum. Something that we've learned from experience from Bascom Palmer about FEVR, exudative retinopathy versus ROP. This ROP roper that we've learning to kind of understand a little better. Your experience is that the fact that ultraviolet field can show you these tangled vessels which in a very atypical way pop up into the peripheral vascular zone, the vascular segmentations. Your experience with this, and how often, like on a scale of 0 to 100, would you expect to see that in our population?
Honestly, we've not done such a large-scale study to talk about percentages, but definitely, as you said, the features are slightly different. Many times, and consanguinity is very, very common in Karnataka and probably in Tamil Nadu as well. So one always has at the back of the mind that this could be an FEVR variant, and especially when these babies are really at the borderline of 2 kilos. But I think what sets it apart, other than the vitreous pathology, is the fact that the plus disease is so much lesser compared to the disproportionate amount of disease that's there in the periphery. So the fibrovascular, the vitreous pathology is so bad looking in the periphery, but when you look at the posterior pole, there's hardly much, in comparison, the plus is not so severe. So this is one of those places where your antennae go up and you're like, are you dealing with a roper? And many of them don't really have that stormy postnatal course, but honestly, it's just not possible to be absolutely sure until we do the genetic study.
Sure. Also, just a question, and also comment. I think earlier, it was a little misunderstanding. I mean, when I meant multicolor imaging, I meant, of course, red-free for retinal, but with multicolor imaging, you also get a look at the vitreoretinal face also. That aside, but also, I just want a lot of the action is in the periphery. So how far do you see for a new setup investing in technology and imaging technology, ultra wide field, angiography feeding of what Ashay said, how useful and how impactful would it be for a modern retinal practice going forwards, and also ultra wide field OCT angiography? And also in your cases, did you use the flying baby technique for most of this advanced imaging?
So I think a wide field Optos-like angiography for pediatric retinal conditions is a blessing, is a boon, but if you don't have it, you can still really do a good job. Just to tell you what Mike Treacy does nowadays, he says, all his FEVR cases, he follows up 6 monthly or annually only on wide field angiography. So I think that is probably where we all need to aim at. But even with the 120, 130 degrees, what you get with a neo or a RetCam, fairly sufficient to come up with a conclusion, conclusively what we can see and do. Only thing, because it's a contact camera, it's very difficult to do it in a slightly older child. Flying baby, yes, we did it for that first case report. It was an 8-week-old child and it had aggressive ROP. But for that subsequent paper that we published, which I showed the screenshot of, they were all 5 to 10-year-olds. We chose that because we wanted to correlate the FAZ with their vision and their so-called normal-looking macula. So there we did not need any flying baby. They just sat at the Heidelberg and we got that.
Sir, I had one very quick question. When you do the angiography, especially when you have a zone 1 or a zone 2 and you're given anti-VEGF, and we know that after 4 weeks, there is no much progression. But a few of the authors, I don't remember the exact name, they have described that if it tried to progress with at least 2 disc diameters of the size from what the original ridge was, and if it doesn't progress more than that, then usually these are the cases of recurrence and these require a second anti-VEGF therapy. So how long would you wait? And if you want to document it doing an angiography in the first instance, and then you give an anti-VEGF and then you again document it and you see that there is only 1 disc diameter of movement of the edge, what was there before. So what are your treatment conditions? Would you like to repeat angiography in these cases, or you straight away go ahead for laser?
Okay, so great question. And not all those questions have been answered worldwide. So I'll give you the general consensus and what we are doing in India through, let's say, the IROP Society, general consensus. So as far as pre-anti-VEGF angio, if you are going to do, you're really going to do it if to decide there's capillary non-perfusion in the macula fovea or not. If the CNP in the fovea, it's a great candidate for anti-VEGF. If there's some amount of capillaries in the macula, you might even want to go with laser, but that's a separate discussion. Now, what happens as far as the growth happens? So once you give the injection, it depends on which drug. If you're giving ranibizumab, the progress is much slower, recurrences are much faster. And by faster, I mean sometimes between 2 weeks and 4 weeks. If you're giving bevacizumab, which is Avastin, the recurrences happen much later, sometimes 12, 16 weeks, and as reports go, even 2 and 3 years later. So the question is, how long are you willing to wait? So if there's a recurrence anytime, whether it's 1 week, 2 weeks, or 10 months, you're going to treat. There's no question about it. And most of us, and I would say 99% of Indian ROP specialists will do it with laser and not with a second injection. Now, what happens if there's no recurrence, but the blood vessels are simply growing forward ahead? Then, yeah, that's where the consensus is not there. But what are we generally looking at? We want the vessels to at least grow into zone 2 anterior. That would be our aim. Once it grows into zone 2 anterior, we are like, okay, we've saved a decent amount of retinal real estate. Now let's go ahead and laser. But what if the baby is now 10 kilos by then? That means you'll have to laser under general anesthesia. Do you have the facility for GA? Is the child systemically okay to sustain GA? So therefore the question comes, and I sort of written a small editorial in IGO on this. There are about 7 or 8 factors what we might consider on when we go ahead and do the second treatment. So the weight of the child, the age of the child, the drug used, the dosage used, and if you have the angiogram, to look at the edge leakage. If the edge is leaking and the blood vessels have reached zone 2 anterior and the child is about 4 or 5 kgs, and that's your comfort zone of doing it under topical anesthesia, I would say do it. So 52 weeks should be your cutoff, which is 3 months from the due date. 40 weeks being the due date. So if you're at 52 weeks, normal fovealization and peripheral vascularization should have ideally occurred. And if it isn't, by now the child is about 5.5 kilos. So if you are comfortable doing the laser, go ahead and do it then. If you're fairly confident of following up the baby for another 8 weeks, then do it under general anesthesia. Most people in the West would wait till about 55 or 60 weeks. Here in India, we do it somewhere between 48 and 52 weeks. Sorry for the long answer, but this is where the consensus is.
It is a question of debate, because many Westerners have started doing second dose of injection, third dose of injection. But in India, I think the consequences are different, as you rightly explained it. Thank you.
Thank you very much, Dr.